the two eminent speakers. I have to maintain the data run rate as well as I have to maintain the data quality. My topic is management of leptospira. Management of leptospira has the many issues. I am going to cover only the diagnosis and the antibiotic part of the leptospira, because when I went through, I'm mainly coming from the private sector. My hospital is 550 bedded hospital which has a 120 bed critical care, and we are coming across 2000 admissions per year. And if you go through this load and drainage, we are facing a lot of problem, and I am quite sure you are in your setting also facing the problem while managing the leptospira. And these are going to add into these things. It's just introduction. Leptospira is recently declared as a re-emerging infectious disease. And look at these. I want to just concentrate on the mortality and morbidity. The range of the mortality and morbidity is 5 to 40%. Why so much range in the management of leptospira? In fact, it is so straightforward disease to diagnose. So where we are lacking, where we are facing the problem in diagnosis of leptospira? This is the one problem. So many synonyms for the leptospira, they will add into the further confusion. So what are the key factors? To start with, the key factors are prevention. Always prevention is better than any part of the treatment. Then early diagnosis and early treatment. Probably we are lacking in early picking up the diagnosis of leptospira. Probably we are lacking in offering the treatment to the leptospira patient earlier. And that's why mortality is ranging for 5 to 40%. Still, it is the truth. So this is a typical scenario. 6-year-old male was admitted in ICU with a history of fever, intermittent fever, cough, lethargy, dyspnea, vomiting, and family also noted in retrospect that he looked like a jaundice. So it is a common scenario. Whenever such patient comes, most probably in the rainy season, the diagnosis is leptospira. But it's not so straightforward. There are so many differential diagnoses. You cannot say that with sure it is not dengue fever. Might be it is hepatitis of the various etiology. Might be it is viral meningitis, enteric fever, malaria. So you have to offer like a blanket type of the treatment. So why there is so much differential in the diagnosis? So while considering the particular leptospira, you have to say that you have to confirm the diagnosis first. And another aspect of the diagnosis is to determine the extent of the organ involvement and to know the severity of the complication. That's going to decide your morbidity and mortality in the management of the leptospira. So extent of the organ involvement, you can do the routine hemoglobin. Hemoglobin, you will find it is rapidly deteriorating, might be because of the bleeding in the lungs, bleeding in the abdomen, anywhere because of the thrombocytopenia. Kidney functions, you will find deranged. Liver functions, you will find deranged. The coagulogram, you will find deranged. But to confirm the diagnosis, to coming back to this thing, there are so many things or so many diagnosis tests are available to diagnose the leptospira. You can isolate the leptospira from the human body tissues. You can do the serological tests like ELISA. You can do it on the urine, CSF or the blood. You can do the SAT, that's the sliding agglutination test. But still, the gold standard for the diagnosis of leptospira is a MAT, that is a microscopic agglutination test. And you can do the culture. So, problem is whether these all tests are available at your center, whether all these tests can be easily done, the cost of the test, then the appearance of once the leptospira infection happens, it takes 5 days. More than after the 5 days, it appears in the urine and the blood. If you try to do the culture, it takes more than 2 weeks to develop on the culture. So if you do which is the diagnostic test, is the microagglutination test. It comes positive after the 10 days. The problem with this test is that it remains positive for weeks, months, or sometimes in years. So to differentiate in between the recent or previous infection, it is not possible with this test. But still, these are the tests available. How you are sensibly reading this test, how you are utilizing this test, decides the diagnosis. And whether it is enough to say that it is leptospira on the basis of the only diagnosis test is another controversy. So if you go in the first 2 weeks, this test you can offer to the patient for the diagnosis. In next few weeks, you can offer these are the tests. Now this is Ruby Hall data. This is our hospital data. Last year, we did the PCR. Hardly any patient got diagnosed. We did the IgM antibodies. with a 6% positivity, and IgG it is a 1% positivity. This looks quite unusual, but when I go to the literature, I went to the other thing, and we find these are the things which we should consider in management of the leptospira quite carefully. Like, what are the dilemmas? Dilemma is that if you do the ELISA, ELISA is always indicates the recent infection. If the ELISA is positive, you can say that this patient is having the leptospira which he recently acquired. If the PCR is positive, again it indicates the recent infection. But the problem with the diagnostic gold standard test, which is the microagglutination test, it is either recent or previous infection because it remains positive for weeks to years. So you have to do the quite sensible reading of the test. If you do the ELISA, it is okay, it is straightforward leptospira infection. If you do ELISA and MAT, ELISA is positive and MAT is also positive, again it confirms the recent diagnosis. But if you do the only MAT, if it comes positive and if you want to make sure that it is the recent infection, then you have to do ELISA. Because if in this patient particularly, if ELISA comes negative, then it might be you are dealing with the previous infection. So not only to select the test, not only to do the test, you have to sensibly read this test for the diagnosis of leptospira. To avoid all these things, in a management of the leptospira, there are the clinical, epidemiological based and laboratory based criteria. It is a FAINS criteria. WHO designed this criteria to get the maximum out of the diagnosis. Suppose if on the basis of the only diagnosis test, you can diagnose the leptospira 18%. There was a good article in the JAPI in 2003. They did something 118 patients and only 22 came positive diagnostically, either ELISA or MAT. And then they apply the WHO guideline criteria. If you do this, they give us the points. Because of the lack of time, I didn't have that. Have the points for the clinical patient, fever, jaundice, headache, vomiting, like that. They have the points. Then epidemiological means in Western countries they have the animal contact is one of the commonest cause of the leptospira. And laboratory diagnosis they mention the MAT test. So if the total score more than 26, then it is diagnostic of the leptospira. But in problem with our Indian scenario, Shiv Kumar from the Chennai pointed that the animal contact or which we cannot consider positive finding in epidemiology para. What is said, rainy season or contaminated, these are the things we should replace in terms of the animal contact. And ELISA, which is easily after within the 5 days, do it along with the MAT. So we the diagnosis. So at the end of this thing, what he come up, if you only diagnosis of the leptospira on the diagnostic test like MAT, the 18%. If you have the FAINS criteria, increase the yield to the 40%, 40.8%. And if you use the modified FAINS criteria, which was based on the Indian experience, you can increase up to the 58%. So that's how you can increase the diagnostic, and that's what this particular says. If you use the standard FAINS criteria, the sensitivity is 41%, but positive predictive value is 9%. And if you use the modified FAINS, positive predictive value is 85%. So the quite significant p-value. Then once you diagnose, you have to come to the next part is the treatment. Typical antimicrobial treatment, then supportive line of treatment, organ specific treatment, and prevention. So like you have to pick up the leptospira earlier to offer them the earlier treatment. Pick up the leptospira earlier and results will be better. Offer the antibiotic, the results will be more better if you offer the treatment. So these are the drug of choice. Penicillin is still gold standard. Penicillin, amoxicillin, doxycycline, mycin, along with the doses. So earlier you will find the better results in the lab. doses: penicillin 20-24 million per day. Doxycycline, you can use it for the therapeutic as well as the prophylactic. Therapeutic dose is 100 milligram BD. Prophylactic dose is 250 milligram once a week. Pediatrics not yet established efficacy. Then another drug of choice, erythromycin. One of the advantages of it, if you use if they allergic to penicillin or in pregnant patient, you can erythromycin. Dose is 500 milligram 6 hours. Sorry for the slide mistake. In severe leptospira, you can generation cephalosporin, either cefotaxime or ceftriaxone. Again, there was an article in Medical Journal, which there are certain suggestions like carbapenem they are by use. What they said, the third still gold standard for the C. If at all, if you want to use the antibiotic, it should be based on your ICU experience, your ICU scenario, and you can try the antibiotic combination indication. Organ involvement, you can choose your. These are the antibiotics which are suggested for management. Organ specific management in terms of continuous cardiac monitoring, mechanical ventilation and airway protection is needed. Renal dialysis according to indication, treatment of shock in terms of the fluids, and other parameters. Supportive in terms of the normalization of the electrolyte balance, correction of the bleeding parameters, phosphorus, hyperphosphatemia. Now, one of the most complication of the leptospira is thrombocytopenia. That frequently asked to what value you should treat. Difference of opinion. If you have to use the standard, if you have to treat with the plasma platelet, the patient should have the bleeding, and if the standard criteria you are following in the other sepsis, there is indication of any frequent use transfusion in thrombocyte in leptospira. These are the frequent queries. What is the role of the change? What is the role of the steroids? What is the immunoglobulin? Again, no evidence suggests or there is say that there is a route these therapies. There is a case. There is a very good case reports in case by case. You can decide this with your own experience. It is available in your ICU. You may use these facilities. No scientific evidence. The few case reports like and continuous venous hemofiltration. This is the report. Then there is the role of the dose of the steroid. In this particular methylprednisolone bolus for first 3 days, followed by 1 per kg for next 7 days. It's a case-based report, so you have to take it with salt. Massive pulmonary caused by the leptospira successfully treated with the side and hemoglobin. Again, it is a report. You have to with your own experience. Prevention. So these are all topical infections. Should seriously think about first, avoiding or reducing the contact potentially affected animal, contaminated water and soil, which is our scenario. Wear the protective garments. Vaccine in animals, in human beings, there is no data suggesting fullness of in preventing the leptospira. Those who are in a frequent contact with animals or contaminated water, take the doxycycline 250 milligram 1. And most important thing is education. For the key for the leptospira management is early diagnosis. Pick them early as early as possible. Defined FENS criteria, treatment, and prevention.
I thank Dr.